Hello, everyone. A very warm welcome to you from the Australian National University here in Canberra. I hope that you and your loved ones are keeping safe and healthy. I'd like to start by acknowledging the Ngunnawal and the Ngambri people who are the traditional owners of the land where ANU is located and from where we are broadcasting to you today from. And I pay my respect to their elders past and present. A number of you are joining us from other parts of Australia and the globe, and I pay my respects to the traditional owners of those lands too. We are very pleased today to welcome attendees from various parts of Australia and the globe, including India, Fiji, Burma, etc. Knowledge is power, and our weekly webinar series allows us to share and learn from each other's experiences during the pandemic. Today, we are delighted to have with us Associate Professor Basu Gopal from the Alfred Hospital here in Melbourne, Australia. And I'll come to a more detailed introduction on him in a couple of minutes. Before we start, some housekeeping notes. You will have noticed that your videos and microphones are off. This is just to improve the sound quality for the session. You will also notice a Q&A button on the screen below. Please use that to answer questions at any point during the session, and Professor Gopal might get to it in between if he has time or at the end of the session. You can choose to submit your questions anonymously. Please note that the talk is being recorded. If you have any technical issues or feedback about the session, please don't hesitate to contact us on international.health@anu.edu.au. Before I introduce our speaker, I'd also like to thank Xavier McMahon, a medical student volunteer from Bond University who is helping us with the program. Thank you, Xavier. With that, I'd like to introduce Associate Professor Basu Gopal. He is the lead transplant nephrologist at the Alfred Hospital in Melbourne and an associate professor at the Monash University Central Clinical School. He was trained in medicine and nephrology at Christian Medical College, Velo, my alma mater as well, and previously served there as professor of nephrology. He serves at the International Society of Nephrology, the ISN, in many capacities, including ISN Academy Subject Editor for CKD, Education Work Group member, and South Asia Regional Board Advisory member. We're delighted to have you with us, Basu. He is going to provide a talk today on the effect of COVID-19 on the kidney. So you've got a brief overview of the topic there. With that, I'll hand over to Basu.
Thank you, Deepthi, for the opportunity, and I'll share my screen. Thank you, Deepthi, for the opportunity. You've been very patient with me through this organizing the program, and I hope I can do justice to the topic. So today we're going to discuss COVID-19 and the kidney, and I've intentionally put it there, let's learn together, because this is a pandemic, and luckily for us in Australia, we've had probably less number and less percentage of cases affecting our patients compared to many other parts of the world. And I've learned a lot from international experience, sharing with colleagues and so on. So I'm here to kind of list and discuss a few issues that come up in the interface between COVID and the kidney, and hoping to have some discussion at the end if we have time. As far as COVID is concerned, I don't have any disclosures. So we've had 250 million deaths, million people affected with COVID globally, and about 5 million people who have died of COVID. And this is a pandemic which is a huge impact on everybody in this world, and we're going to look at how this impacts the COVID impacts the kidney disease population. Now, before I go into the details, I'd obviously talk about COVID and acute kidney injury because that forms the majority of what kidney impact the COVID has. We'd also talk about how it affects patients who've got GN and end-stage renal disease. I'd very briefly talk about the impact on kidney transplantation. Solid organ transplant and COVID is another big area with a lot of discussion. And today I will not be talking about COVID vaccination and response in dialysis and transplant. That again is a big area of discussion, and that'll need to be done. That and transplantation would need a separate discussion in itself. So if you look at SARS-CoV-2 pathogenesis, we all understand that the virus has got spike protein, which latches on to ACE2 receptor and then enters into the cell, where its RNA encodes for its various proteins and further RNA, which then results in virus formation and virus replication, which then leaves and attacks other cells. Now, when this reaches the lung, it not only causes damage to the lung alveoli, it also enters into the capillaries and it circulates through the bloodstream, and it causes an immune response, which has several local as well as systemic reactions. We know that locally it causes lung damage in the term of in terms of inflammation, fibrosis, and pulmonary edema. And systemically, it causes significant inflammatory response. As in the pre-symptomatic phase, there is an increase in the viral counts, which then reaches a peak and then starts to come down when the immune response begins. In mild to moderate illnesses, the immune response is such that the symptoms would be present for a few days, and then the patient recovers with the improvement in the immune system's ability to handle the virus. And as you can see, the antibody levels continue to rise here. Whereas in those patients who there's an imbalance or there's a delay between the viral replication and systemic infection and the immune response, there is severe illness, and that sometimes is characterized by the delayed immune response that the patients develop, or ineffective immune response, which then results in further organ damage, and sometimes it can result in critical illness. As you know, the risk factors for COVID, acquiring COVID or having a poor outcome with COVID include old age, hypertension, diabetes, heart disease, kidney disease, as well as obesity. Patients would present with cough, dyspnea, lung involvement, and multi-system disorder. And this multi-system involvement is characterized by multiple organs, including acute kidney injury in about 5 to 45% of patients, GI symptoms in some, and strokes and thromboembolic complications in many others. The COVID acute infection symptoms would usually last for about a couple of weeks, and the patients usually respond if they have a milder illness. And this is characterized by an early phase of an antiviral immune response and a later phase when there is an inflammatory immune response. And often the chronic organ damage happens, the acute organ damage happens during this period of acute infection. And then there is a chronic organ damage at the clinical sequelae that persists for long, and that's now called as long COVID. And this long COVID, what is or post-acute sequelae of COVID, results in persistent symptoms as well. Now, let's look at how COVID affects the kidney and what is the interface between COVID and acute kidney injury? Pretty much every respiratory viral pandemic has been associated with acute kidney injury, be it the influenza or the SARS-CoV-1, or which happened in 2003. There was acute kidney injury, which was associated with quite high incidence of mortality. Influenza, MERS virus infection was also associated with quite high incidence of mortality, and a similar incidence of higher incidence of AKI and mortality is observed in SARS-CoV-2 as well. Now, AKI is a common complication. It's about, initially it was reported in a smaller population, about 5 to 25%. As you can see in China, it was reported at about 1 to 29%. However, the US data showed that the AKI incidence is probably much higher at 19 to 43% among hospitalized patients. And the UK data showed that it was around 20 to 27%. AKI, there were two patterns of AKI, one that would develop at admission, the other that developed later. AKI in patients who reach critical care settings can be as high as 50%. And mortality was very high and associated with AKI. AKI in those needing renal replacement therapy, similar to AKI in other multi-organ failure in the critical care setup, had high mortality. The true incidence of AKI is quite difficult to ascertain because of varying denominators in the studies. So some studies are population-based, some studies were outpatient and inpatient-based, and some studies were simply in the ICU setting. And there are also variable underlying risk factors. For example, possibly in the Chinese cohort, there was younger people with lesser comorbidities, whereas that's not the case in the cohort from the United States. And most centers would only have used acute kidney injury criteria based on creatinine, and urine output criteria is very rarely used most often. Many CKD patients have AKI on CKD, and chronic kidney disease patients who develop COVID were usually pushed on to needing renal replacement therapy quite quickly without having to have significant symptoms to push them into ICU settings. So what are the features of acute kidney injury? As I said, in the hospital setting, at the peak of the pandemic, it was as high as 45%. While most of these patients would have mild AKI at stage 1, about more than a third of these patients had quite significant AKI, and about 20 to 25% required renal replacement therapy. When the patient was critically ill and needing ICU care, the rates of AKI were quite high. They were about 50%. That means 1 in every 2 ICU patients ended up having acute kidney injury, and about, again, half to 2/3 of them would require renal replacement therapy. So this was in an ICU where there's already a high load of those who require mechanical ventilation and respiratory support. This would stretch the ICU capacity by needing a high incidence of RRT in those patients. There's a wide variation, as I mentioned, in the AKI rates, but important to also note that at the beginning of the pandemic, the AKI rates in ICU were quite high because possibly patients were being picked up later in their clinical course and the management strategies were just being developed. And a couple of studies have shown clearly that acute kidney injury rates in the hospitalized patients and in ICU settings have declined after the initial time of the pandemic. So in this hospital study, it declined from 40% to about 20%, almost half, over a period of 6 months without any new therapeutic agents being used. It's just identifying the condition and managing that effectively in the critical care setting. Who are the patients who develop risk factors for AKI? What are the risk factors for AKI? So I find that one of the questions here is, does ethnicity have an impact on the rates of AKI? I could answer that at the same time. So as you know, Age, hypertension, diabetes, heart disease, and COPD have been shown to have significant impact on AKI. So that these patients who are older age group, hypertension, high diabetes incidence, heart disease, and COPD have a higher incidence of AKI. Now, this is because the underlying CKD or low eGFR is an underlying pathogenetic mechanism in all of these patients. So there's a proposed factor that all of these conditions imply that the patient has a reduced renal reserve. So normally a patient could have a GFR around 100, but their kidney could expend their GFR to a little bit more in times of stress. This reserve is reduced in elderly, in those who have diabetes and hypertension, other microvascular disease, COPD, and cardiovascular disease. And in those patients, an additional insult such as COVID kind of reduces their kidney function quite rapidly. Whereas in the ones who have an intact renal functional reserve, that decline doesn't necessarily reflect in the kidney measurement, the GFR measurement, as a decline in GFR. So that essentially explains why all these patients with these risk factors have increased risk of AKI. And that's when that's where ethnicity comes into play. Not so much because of the genetic makeup, but because of the variable risks in age, hypertension, diabetes, and heart disease in the different ethnic population. For example, I can tell you that the acute COVID population in the Indian subcontinent is likely to be much younger compared to the one in, for example, Australia or United States. And therefore, you find that the degree of acute severe COVID may be lesser in a younger population, and therefore a lesser degree of acute kidney injury. Contrarily, in the UK data, we found that a lot of ethnic background population, including Blacks, African origins, Arab origin, or South Asian origin people, had higher incidence of worse outcomes. And that's because compared to the white population in United Kingdom, these ethnic groups have likelihood of less residual renal function or functional reserve of the kidney. So the impaired capacity of the kidney to increase the GFR in response to stress and reduced functioning of nephron mass is an important factor. Now, how did acute kidney injury present? It's again a very interesting phenomenon here. So obviously, usual acute kidney injury presents with the increase in creatinine and decrease in GFR, and those needing dialysis or kidney replacement therapy. We also had a significant population of patients who had proteinuria and hematuria. Hematuria was present in almost more than half of the population with acute kidney injury, and proteinuria was present in more than 2/3 of the population. And this was subnephrotic and predominantly tubular proteinuria, indicating a tubular dysfunction. But more interestingly, there were patients who had Fanconi Syndrome. Quite a significant proportion had Fanconi Syndrome. For example, phosphaturia was present in about 50%, hyperuricosuria, and even normoglycemic glucosuria was present in about 30%, indicating that there was active tubular damage even before creatinine rise in these population, indicating that kidney damage happens probably in a much wider population than what is demonstrated by the rise in creatinine. And Fanconi syndrome is observed early on before the actual rise in creatinine in many of these patients. If you look at proteinuria, and I said 70% of patients initially were reported of proteinuria. That is variable. In some reports, it was as low as 30%, with others it was about as high as 90%. And in acute kidney injury population, there were higher incidence of proteinuria. The proteinuria is also very interesting. We know that the tubular injury because of the virus. The phenomenon of ischemia, sepsis related tubular injury can cause tubular proteinuria, which is a low grade proteinuria that we commonly observe, and it's directed during a case of COVID-19. Interestingly, there was also quite a few patients, especially in the United States, who and of the Black African American origin patients who had significant nephrotic range proteinuria. And there were other population, especially the ones who have chronic kidney disease, who had proteinuria that was of a higher degree than just what is expected. And that is because of this particular manifestation of renal injury, apart from the tubular dysfunction, which is called COVAN or COVID-associated nephropathy, where a specific glomerular pattern of injury called collapsing glomerulopathy is noted, especially in the high-risk ApoL1 genotype population of the African-American origin in the US. This genotype is quite rare in the rest of the out of Africa world, other than in US, and especially not very common or not well known in the Asian population. So that's something that you may not see much collapsing glomerulopathy in the Asian population. What else do we know about acute kidney injury? There were a lot of autopsy studies to look at kidney pathology in the early patients who passed away. So common findings were acute tubular necrosis, which is the common routine AKI that we get with sepsis. But more interestingly, as I mentioned, 40% of the population had collapsing glomerulopathy. And also thrombotic microangiopathy in the kidney was noted in about a third of the patients. And interestingly, all of these kidney tissue did not have active viral, or at least did not have a PCR positivity for virus in them. So it wasn't like there was direct viral invasion that was obvious in these kidneys. What was interesting was this study which looked at patients who had moderate and severe disease, both in ICU and the non-ICU setting, and did kidney biopsies if they've had acute kidney injury. And they found that in the severely ill patients, those who have significant symptoms and reach an ICU setting, there was a higher incidence of tubular injury of ATN, whereas those who have mild to moderately ill patients, the pattern of injury was predominantly collapsing GN. And again, this study confirmed that they did not have virus in the kidney. There's a question that says, was the incidence of AKI higher with the alpha variant compared to the delta variant? There was no significant difference in the incidence of acute kidney injury between the variants. But it's important to note that we'll come to the incidence of acute kidney injury over time. With time, there was a decline in the rate of acute kidney injury because of better management principles. Early on in the pandemic, ACE inhibitors were withheld. Did they reflect the number of patients with AKI then and now? After the damage, data emerged on ACE and ACE were not withheld. It's quite possible that ACE inhibitors contributed to some improved survival in the later half of the pandemic, but it's very difficult to be quite pedantic about whether that's all attributable to just ACE inhibitor as well. Now, kidney disease does occur in pediatric cases as well. The reported frequency is quite variable because, as you know, pediatric population, which reaching ICU and reaching hospitalization was quite uncommon in the initial wave. And most of the data we have are from 2020 to early 2021. And it's only in the later half of 2021 that we've seen a lot of kids, especially in US, who have with the Delta virus variant have reached hospitals as well as ICU. So the data is still not clearly available as to what the rate of AKI is, but I'm more certain that the Delta related AKI in children would be higher compared to alpha virus related AKI. Anyway, going on with the histological changes. So tubular pathology is quite common. As I said, 67% of patients in ICU have acute tubular necrosis or tubular injury, whereas 70% of non-AKI, non-ICU patients had collapsing GN. And electron microscopy revealed numerous tubular reticular inclusions and in endothelial cells. These biopsies, when they were stained for COVID, they couldn't find any COVID viruses, both in the glomerulus as well as in the tubules. This is a positive control for placenta that you're able to see, that clearly demonstrating that the kidneys were negative. There was not, the direct viral invasion was not a major pathogenic mechanism. So the most important pathogenic mechanism was that of endothelial dysfunction. So as you know, SARS-CoV virus not only enters the endothelial cells because they have upregulated ACE expression. They also trigger an inflammatory immune response in the blood vessels, which cause an oxidative stress and cause vasoconstriction, as well as endothelial vascular permeability is increased. This results in both a peripheral leak of intravascular fluid, as well as an increased risk of thrombosis and thromboembolism. I'm keeping it very simple here because we don't want to go into details of the cytokine mechanisms here to understand what's happening in the kidney. So the microvascular injury affects major organs, and the one that is very clearly described is that of myocardial injury with thromboembolic episodes. Also in the brain, there's pulmonary embolism, there is deep vein thrombosis, but a similar endothelial injury mechanism causes the renal ischemia pathogenesis as well. So similar to what happens in the lung, the pathogenesis in the kidney is quite similar. So there is thrombosis, there is embolism, there is fluid leak. So the viral infection happens at the kidney endothelial cells. It causes microvascular inflammation. There is complement activation. There is endothelial dysfunction. There is also platelet activation that subsequently results in thromboembolic phenomenon, and all of this cause significant injury to the kidney as well. There was this very elegant study done by the Mayo Clinic pathology group. And I want to mention Priya here. Priya is one of our, again, Vellore alumni who's doing excellent work in renal pathology in Mayo. This study looked at transcriptomic and proteomic analysis of patients who had COVID-related AKI and similar patients who had other infection, sepsis-related AKI and non-sepsis AKI. And what they found was very interesting, that the various proteomic and transcriptomic gene expression analysis revealed that most of the similar processes are activated in both the AKI between COVID and sepsis AKI. The immune response and microvascular inflammation is similar. There is similar activation of apoptotic signals. There's also similar activation of necroptosis and mTOR signaling pathway, all of which indicate that the acute kidney injury in COVID is pathomechanisms of that are quite similar to septic AKI, and the mitochondrial dysfunction seems to play a significant role in COVID AKI. Now, there's still more interest in whether direct viral invasion causes significant AKI. So postmortem kidney tissues were analyzed in another study here, where you could see that 60% of their analytes had SARS-CoV positivity, and these were kidneys of patients not just with COVID, but with COVID with AKI. And what was interesting was the increased incidence of AKI means that there were more virus in circulation and therefore more virus in the kidney as well. And this led to the speculation whether kidney injury was predominantly driven by direct viral invasion, the initial studies, there were very few studies that supported this with in situ hybridization of viral RNA and viral particles. But these were very occasional studies. Most of the studies that looked at kidney biopsies could not find any viral particles or could not stain for the COVID virus in a large manner. And there were a lot of subcellular organelles in electron microscopy that look very similar to the virus. For example, these are actually viral particles here on your on the right. And on the left, you see subcellular organisms which were being mistaken for viral particles, and they were just usual, secretory vesicles and Golgi-coated vesicles, etc. So it is very difficult to prove that the virus actually entered the kidney and therefore caused significant damage. Now, this is a very interesting study, and it came out only a couple of weeks ago, where the authors looked at mini kidneys in a petri dish, and they tried to infect those kidneys with SARS-CoV-2, and they found that the SARS-CoV-2 virus would only infect the proximal tubular cells and cause damage to those kidneys cells only. And this was again ACE expression dependent. So we saw that the virus entered the proximal tubular cells and it caused a signature of protein expression that's very similar to that seen in the urine of COVID patients, indicating that possibly a lot of COVID patients do have proximal tubular invasion of the virus, and it might trigger the initial Fanconi syndrome that we think about, causing AKI. But then the systemic immune response kind of takes over, and that causes a much more significant damage than any direct viral cytopathy. There's a very small proportion of patients who get acute interstitial nephritis, and this could be due to various reasons. So one is, of course, whether the virus itself causes inflammation, but that's very rare and very difficult to prove. There were lots of drug-induced AKI, and there were other patients, other conditions that could cause acute interstitial nephritis. For example, there are various drugs that were proposed as treatments, including azithromycin, hydroxychloroquine, and some of the traditional medicines which are quite, which were quite popular in South India, were resulting in significant acute interstitial nephritis, and of course the antibiotics that were used to treat the secondary infections. Additionally, COVID also resulted in autoimmune diseases and secondary HLH, all of which can cause acute interstitial nephritis, and that cause significant, even granulomatous interstitial nephritis has been reported. This is a case report from Chennai of a patient who is taking the traditional medication and causing a drug-induced, traditional medicine-induced acute kidney injury or with acute interstitial nephritis. Now, there's a good question from Girisha. He's saying, is there any data to show at the time point in disease when the virus invades the proximal tubules? It'll be very interesting if we can actually tag the virus and look at when it actually enters the kidney. But that's, at the moment, there's no data, but it's postulated that given the way the virus is present in the system, in circulation, and the fact that tubular cells express ACE2, and the initial form of acute kidney injury being Fanconi Syndrome, which indicates some kind of proximal tubular dysfunction, it's presumed that if at all, this was a very early part of the pathogenesis and not necessarily much later. What proportion of COVID-related AKI require dialysis is the next question. Have renal transplants been done in this setting? So we'll come to COVID-related AKI requiring dialysis. I've got some more data on that, and we'll have that question. There's some management question which I'll come to later. So other causes of acute kidney injury in COVID. So, there was a high dose vitamin C increase, and there's this case report of how that resulted in oxalosis and oxalate deposition in the kidneys. You can see in the dark field microscopy here of the renal biopsies, this brilliant oxalate crystals. There's also some case reports of antiviral drugs causing acute kidney injury. So the considerable number of reasons why acute kidney injury can happen, but the most predominant one is that of endothelial dysfunction and sepsis-related AKI. Coming to the glomerular changes that you see in acute kidney injury in COVID. So there's a distinct global nephropathy that happens in COVID, which is usually seen in the non-severe COVID pathogenesis group. So that it causes an isolated AKI without the systemic inflammatory response that you normally see. And these patients have significantly high levels of proteinuria. That's how we identify these groups. It's quite common in the upper L1 variant. In fact, there was a very interesting paper written which said the COVAN is the new HIVAN, which is the HIV-associated nephropathy, which was associated with the upper L1 variant previously. In these patients, infection did not cause a hyperinflammation, and the upper L1 gene interaction kind of modified this and resulted in predominantly a glomerular epithelial injury rather than a proximal tubular injury, and resulting in a collapsing glomerulopathy. The other causes for collapsing lesions could be ischemia, although ischemia is very difficult to prove in kidney biopsies unless there's a clear-cut thromboembolic phenomenon that is obvious. We also saw quite a few patients with almost a third of the patients with AKI had, at least in the biopsies, had thrombotic microangiopathy as part of the, widespread systemic endothelial injury and consequent thromboembolism. In fact, cortical necrosis, which is not uncommon in Asia, but quite uncommon in settings in the US, were reported in such patients who've had thromboembolic phenomenon of the kidney. So predominantly it's endothelial dysfunction, but occasionally in patients there was autoimmune phenomenon reactivation from the COVID infection, resulting in antiphospholipid antibodies and therefore secondary TMA from that as well. So either the kidneys had quite obvious thrombotic microangiopathy, or they had very subtle damage, but the thrombotic microangiopathy could only be picked up in with endothelial cell injury in the electron microscopy. There were several other reports of GNs that were noted for the first time in COVID patients. So post-immune GN, especially with anti-GBM and ANCA, with new onset anti-GBM and ANCA and antibodies were noted. Anti-GBM is quite understandable. You've got both pulmonary and renal tissue sharing the same collagen subtypes, and therefore a pulmonary infection could possibly result in anti-GBM antibody formation that can then subsequently affect the kidneys. There were other podocytopathies, FSGS and minimal change disease. There was increased reports of membranous nephropathy, IgA nephropathy, vasculitis, lupus nephritis, flare, etc. Autoimmunity is quite a common phenomenon in COVID, and in fact, a series of autoimmune diseases have been described. As you can see, this is taken from a review article on the autoimmune impacts of the kidney, of the COVID, and one of them is glomerular nephritis. Of course, there are quite a few, the multi-system inflammatory syndrome or Kawasaki-like disease that's well described in children. You have chilblains, a COVID fingers, a COVID toes, Guillain-Barré syndrome, immune thrombocytopenia, hemolytic anemias, and of course, autoimmune thromboembolic phenomenon are all quite common. And the glomerular nephritis, it's been said that it happens predominantly in the early phase of the COVID disease, whereas some immune-mediated, like the autoimmune mediated diseases of glomerulonephritis that have, for example, the lupus flare or the membranous nephropathy happen later on in the course of COVID. What are the other causes of acute kidney injury? Of course, patients have multi-system involvement, and kidneys, in several cases, an innocent bystander, and it can cause myoglobin, cast nephropathy, oxalate nephropathy, renal cortical necrosis, renal infarction, renal artery stenosis, and so on. was there a higher incidence of renal HUS in patients with COVID-related PE? There's the overlap between PE and renal HUS is not very clearly described, possibly because of the fact that these patients may not have had a chance to get their kidney biopsy done, but it's quite possible that there are a group of patients who had endothelial dysfunction, who had thrombotic complications and caused TMA as well. Right. So to summarize the mechanisms of acute kidney injury, the number one mechanism is that of systemic inflammation, systemic inflammatory response syndrome, pulmonary renal crosstalk, and the other organs like the cardiac dysfunction or ARDS, all of that can cause kidney injury as well. Tubular injury is the next most common with hypoxia and hypoperfusion, but also interstitial nephritis and other tubular dysfunction, including a component of direct viral infection. This is followed by glomerular injury with collapsing glomerulopathy, interferon-mediated podocyte injury, and other forms of TMA as well. There is a element of vascular injury, which is predominantly with HUS kind of pattern, as well as thromboembolic complications. And a very small proportion could be interstitial with acute interstitial nephritis or an interstitial edema from the capillary leak phenomenon. What about the incidence of COVID-related AKI and how and its outcomes? So COVID AKI in hospitalized patients significantly had a much higher incidence of AKI at around 40%. This initial report looked at stage 2 or 3 AKI and the risk factors for that as listed here. So, but 50% of the patients, 50 to 60% of the hospitalized patients had AKI, but only about 5% required renal replacement therapy. This was associated with increased risk of mortality as well as lower risk of renal recovery. A larger study looking at critically ill patients, about 3,000 critically ill patients in New York registry, we looked at, and amongst them, 55% of them developed AKI, of which 21% required renal replacement therapy. And of those who required renal replacement therapy, 63% of them passed away. Only 37% survived. And even amongst those who survived, 1/3 of them were continuing to be on dialysis at discharge. And half of them continued to remain on dialysis even after 60 days. That's 2 months from the time they got discharged. So not only is AKI quite severe, especially in the critically ill patients requiring renal replacement therapy, it also seems to leave a lasting impact on the patients with reduced kidney function in the long run. The rates and outcomes of acute kidney injury in hospitalized US veterans was studied in this group. This is a unique population of predominantly men who had a median age of 70. And in this population, those who had acute kidney injury with COVID had a 34% incidence of mortality. So 1/3 of them had acute kidney injury, and 1/3 of those who had acute kidney injury died. And the odds of requiring ventilation if you had acute kidney injury was 6 times. 6 times increased risk of death, and about 6 times increased risk of hospital stay as well. And other than age, there were no other significant difference in the risk factors. And with different stages of AKI, there were increasing risk of mortality. So as you could see, those who had no AKI, only 8% had mortality. That increased to 19% in stage 1, 39% in stage 2, and stage 3 and 4, almost 60% of them had died. Did treatments improve the risk of COVID? As we saw that the incidence of COVID in ICU and in hospitals came down in the first few months after the pandemic. And that's possibly because of improved management plan, as well as identification of the acute kidney injury early on, and managing the systemic inflammatory response. The dexamethasone was studied in the recovery trial, and that's possibly the only drug trial in COVID for general COVID population that mentioned renal replacement therapy as one of its, at least in the tables. And we know that dexamethasone reduced renal replacement therapy need by about 39%. So in the usual care population, need for renal replacement therapy was 7.5%, whereas that came down to about 4.4% in dexamethasone. Several small studies corroborated this beneficial effect of steroids in reducing AKI, and we know that acute kidney injury requiring hemodialysis, the relative risk reduction is about by 60 to 70%. So 40 to 70% reduction in the need for renal replacement therapy in various small studies have been noted with use of dexamethasone, and that explains why some of the treatment induced improvement in acute kidney injury rates subsequently. Neither the tocilizumab nor the baricitinib remdesivir trial clearly looked at acute kidney injury. The remdesivir trial did not report acute kidney injury in its main results, but it was there in the fine print in the supplementary analysis, and there was not significant AKI to comment on. AKI is in the simple moderate study, data analysis showed there was some reduction, but not significant. So what do we do when you need renal replacement therapy in these patients? What kind of renal replacement therapy is used? Indications for RRT are similar to other acute kidney injury situations. Units should plan for the surge for need for RRT. CRRT is the common choice because most of these patients are critically ill, already on a ventilator or intubated, or quite sick and need effective fluid maintenance, fluid volume control in the presence of quite dicey hemodynamics, and therefore CRRT becomes the modality of choice in these situations. And in those places where that is not possible, we could use SLED, or what is known as prolonged intermittent renal replacement therapy, which is a modified version where you give delayed intermittent renal prolonged course of renal replacement therapy with intermittent dialysis protocols. And that's easier to manage in resource-constrained situations as well. There will be a subset of patients who had underlying CKD, who developed COVID and then went on to AKI, who are not otherwise systemically unwell, and they've just lost the kidney function because of the COVID, and they can be managed with this intermittent hemodialysis. And there are reports of peritoneal dialysis being used in resource-poor settings and in when there's resource constraints because of high pandemic load on the system. But peritoneal dialysis may be difficult, especially because you need to do prone positioning in these situations. Now, anticoagulation is of importance in renal replacement therapy because of the high coagulable nature of these patients' illnesses, and often regional citrate anticoagulation is not useful. CRRT doses also can be usually prescribed doses 25 to 30 ml per kilogram per hour, but you could reduce it to up to 20 ml, especially if there's resource constraints. Of course, infection prevention practices, I won't go into this. These are quite important, quite well known. What's important is there are lots of cytosorb and cell absorption, cytokine absorption hemoperfusion technologies available, but these are not very useful, or at least not clearly studied and shown to be of benefit in kidney disease patients.
I think you've frozen,
So,
Basu. I'm sorry, we seem to be having a few technical issues, so we'll be back with you in a minute. We apologize for the technical issues. Should be up and running soon. Basu, do you want to try sharing your screen again?
yeah, sorry, I don't know what happened. Just 1 second. I'll just get this. Okay, I think I might have to log out and come back in. I'm sorry about that.
That's okay. Can you also email the talk to us?
Yes,
and
I will
maybe
do that. Yeah.
we can share the screen.
Patients after they recover from the illness. So this is a study of 5,000 odd COVID patients with end stage admitted to this hospital, the same Veterans Affairs Hospital. As you can see, the orange line here is no AKI, that is AKI stage 1 and 2. They all seem to do reasonably well. The ones who have stage 3 and the ones who require renal replacement therapy, even at 30 days, they have higher creatinine values. And so there's not only increased mortality, but also increased renal dysfunction on recovery. And that is true not just for this elderly men, but also for this group of patients who again had a median age of 70, but 50% were men. As you can see, the other AKI due to other causes had an increase in the creatinine that came down and remained stable, but the ones with COVID, the trajectory was that it was going up and up. And actually the eGFR slope, or the rate of decline in GFR after the acute illness for about 6 months, was only minus 2.6 ml per minute per 1.73 in the non-COVID AKI, but for COVID AKI in that group, it was as far down as 16 ml of filtration loss. So while AKI due to COVID is similar to AKI due to sepsis, it seems that the long-term impact is quite significant compared and higher compared to sepsis AKI. And this forms the part of kidney injury that persists in the long COVID phase. That's a post-acute COVID phase, where not only do you have other organ damage, there's also significant chronic kidney disease that's been noted. So this quite elegant study of Veteran Affairs uses of around 90,000 patients with COVID in the US. And they've looked at eGFR at the time of discharge, 30 days from discharge from COVID, and then up to about a year. And this study is really clear on one thing. Of course, those patients who were hospitalized with AKI had an increased risk of subsequent acute kidney injury or being diagnosed with end-stage renal disease, or what is MAK's major adverse kidney event, which included an eGFR decline of more than 50% or end stage. So you could see that there was significant increase in GFR decline in those with AKI. But what was interesting is even the patients who did not have AKI when they were hospitalized had a decline in kidney function. And even more interesting was the fact that even those patients who were not even hospitalized had a higher risk of acute kidney injury and major kidney events in the future. While those who were not hospitalized lost about 3 ml GFR, those who were hospitalized lost about 6 ml GFR, and those who were in ICU lost about 8 ml GFR over a period of a year. These numbers might look small, but if you consider that diabetic nephropathy patients lose about 10 ml GFR in a year if they have uncontrolled diabetes and hypertension, that is precisely what, and normally you lose only about 1 ml GFR in a year with just aging. So the non-hospitalized patients losing kidney function despite not having symptoms, not needing a hospitalization, clearly tells us that COVID has got a significant impact on the kidney injury, not just in the short term, but also in the long term. Now, quickly, we'll go through some glomerular diseases and COVID as an interface. And there was one question before I go into glomerular diseases. What's the approach of prescribing ACE inhibitors in COVID in established AKI? That's a balancing worsening tubular damage versus pathogenic mechanisms of the virus. Withhold or continue. If they're already on ACE inhibitors, do not withhold. And I would continue even in the presence of acute kidney injury. I think you can juggle that with waiting for the COVID systemic inflammation to settle down to decide whether you want to keep that on or not. But evidence suggests that those who are on ACE inhibitors seems to do better than those who are not, or those who are taken off ACE inhibitors. So that's good. Did the risk related to CKD change through the course of epidemic with improving understanding and managing the disease? Yes, the risk related to acute kidney injury changed, and hopefully because of that, consequent chronic kidney disease would also have changed. Is the renal recovery complete in patients with AKI? We answered that. Even those who have very mild AKI seem to lose some kidney function in the long run. So, and they all inch towards chronic kidney disease of one kind or the other. Lost a little bit of GFR in the long run. So that's really important. How our team prepared your unit to deal with COVID-19 related renal disease? Good question. I think our team is still preparing. Most of COVID related issues have only been a major problem in the last few months in Australia, luckily. And because of that, the increased load of kidney disease and its consequences we probably see in the coming months. As to the numbers, because of, we'll come to Australian numbers and they're quite small, and therefore the impact would be possibly less on us than in some other situations where you need higher need for dialysis in the group, and a clinical load of CKD patients that would come, especially in the post-COVID setting, needs to be managed. In the US, there's a lot of movement now towards promoting peritoneal dialysis and home therapies in that space. We'll come to CKD and transplant as few pointers. Yes, we will. So COVID in glomerular diseases. Now, this interesting international registry of COVID in glomerular diseases looked at GN patients and compared them to non-GN COVID patient or COVID controls, those who did not have glomerular disease but had COVID, but they were age and I think they were matched for several other comorbidities. I clearly looked at a few things. So one was acute kidney injury was much higher in the glomerulonephritis group compared to the non-GN group. And so was need for renal replacement therapy and a higher incidence of mortality in the study. The study was not powered to look at whether immunosuppression had on, like GN patients who were on immunosuppression, whether the immunosuppression modified their risk or not. This is possibly the only big comparator GN study that we have in COVID. Most of other data about immunosuppression has been extrapolated from rheumatological registry. So there's this very interesting COVID-19 Global Rheumatology Association registry that has about 3,000 odd patients with rheumatic diseases of various kinds on various immunosuppressants whose COVID information was collected and analyzed. And it was quite interesting, at least a look at the immunosuppressive drugs and how they affected the outcome. So as you can see, glucocorticoids, especially the ones where patients were on more than 10 milligrams per day of steroids for a longer duration, had a slightly higher odds of mortality. Those patients who were on sulfasalazine and more importantly rituximab, which is quite commonly used in kidney diseases, had a significant higher incidence of mortality. But interestingly, those who were not on any DMRDs, those who were on TNF inhibitors and IL-6 inhibitors, which were all later used in treatment of COVID inflammation, they actually had signals that showed reduction in mortality or no mortality. The ones who did not have any disease-modifying drugs, they actually had a higher mortality, and that could not be explained, but possibly because of the systemic inflammation that they would have developed because of the lack of immunosuppression. So it's quite interesting that some immunosuppressive drugs were actually beneficial, some immunosuppressive drugs were not, and especially monoclonal B-cell, anti-B-cell treatment was considered to be of high risk. This is possibly the only data or limited data that we have on specific immunosuppressive drugs and their impact on COVID. Because COVID caused some post-immune, a few de novo GN, there is a possibility that there's a higher risk of relapse of existing GNs in COVID patients, reduction or withholding of immunosuppression, and infection in itself can trigger relapse in these patients. And there are case reports of either minimal change or IgA nephropathy, or even an interesting case of anti-GBM disease, which is not known to recur very often, coming back in a patient who's got COVID. How do we manage GN patients during pandemic? An important step is to assess the risk of COVID. We'd like to limit their hospital visits, try and promote the usual protective measures such as mask, limit socializing and promoting vaccine, limit the needs for protocol biopsies, especially if it's done for a trial basis. I'll continue the ACE inhibitors. That's one of the questions that was asked. Now, those that can be treated with calcineurin inhibitors, because traditionally, and also in the transplant space, calcineurin inhibitor withdrawal did not seem to make a big difference to COVID outcomes, and therefore we continue calcineurin inhibitor and will try and remove the antimetabolites in these patients and avoid monoclonal immunosuppressants like rituximab in this group. And wherever possible, conservative immunosuppression policy, especially if there's a outrage of pandemic in the community. So if there's a lower risk and they're on some kind of treatment, you could continue that. If there's a higher risk of acquiring or increased risk of mortality from COVID, then in those situations, if they're not yet on immunosuppression, you'd like to start immunosuppression only in significantly high benefit to reduced risk. For example, in the situations where there is the risk-benefit ratio is not that high, you would probably not start immunosuppression. And an individual risk assessment is important. Those who are on CNI could be continued, but those who are needing intravenous drugs, it would be good to put them to oral drugs because then they don't need to access a hospital environment, and avoid cytotoxic agents if possible. And if on antimetabolites, you could interrupt those antimetabolites safely for a couple of weeks, and that shouldn't really change the course of the illness unless they have quite active disease at the beginning. So it's a lot of balancing risks that you need to practice while managing COVID GN patients in a COVID pandemic. There's a question here, why can't we use DMRDs in COVID AKI CKD patient? No, we can use DMRDs. In the rheumatology patients, those who did not use DMRDs, they were the ones who had a slightly higher risk of mortality. And in fact, if you look at COVID management, the first drug that came up was dexamethasone, which is in a way an immunosuppressant and a disease-modifying agent. There are some DMRDs which are not safe for the kidney, so that needs to be kept in mind. And as I mentioned, some immunosuppressants are not necessarily safe as well. Do you know if there's a higher risk of AKI in patients with cancer? Yes, there was a higher risk of AKI in patients with cancer as well, but this is not studied specifically as a risk factor. And it kind of died down in the age and the vascular risk group, but there's there are a few studies which have looked at cancer, and it is an important risk factor for AKI in not only in the general population, but also especially in the transplant population, a risk for mortality in these groups. Right, COVID and end-stage kidney disease. Now, in end-stage kidney disease, I'll go through quickly. I think we've about 15 minutes left. So the initial reports from Europe showed that the mortality rates was as high as 25 to 30%. And as you can see here, this is the data from the ERA EDTA registry, which looked at risk of probability of death in a patient with COVID, about 20% in the dialysis and the 20% in the transplant population. And the higher the age and male gender, there was a higher risk of mortality. The overall mortality was around 20%. But this was a time of steep learning curve and healthcare stress, and things improved from there on. Initial rates of mortality in end-stage kidney disease patients who were hospitalized was quite high at around 30% compared to non-ESKD around 25%. This was again a time quite early on in the journey of COVID, which we've had. And as you can see, some risk factors were quite clear. So those who had very severe COVID had a higher risk of mortality. And yeah. Amongst the critically ill patients, so if there's an end-stage kidney disease patient who develops COVID and then becomes sick enough to go to ICU, they had quite high mortality rate, almost 50% death rate if they had CKD or dialysis-dependent end-stage renal disease and they went to ICU, compared to a non-CKD, non-end-stage kidney disease patient who had only 1/3 risk of mortality. And this is in quite a big study, which looked at about 140 end-stage renal disease patients with COVID versus 3,600 non-end-stage patients with COVID in the critical care setting of New York ICU. And So there's a lot of excess mortality in end-stage kidney disease that is attributable to COVID, and this was studied as a population-based study based on a retrospective analysis of Medicare data. And they found that during the initial wave of the pandemic in US, there was an increase of 17% increase in the dialysis-related mortality and about 30% increase in transplant patient mortality that is possibly attributable to COVID compared to the previous years. And as you can see, the transplant mortality quickly came down, and so did the dialysis patient mortality, but there was still a gap that was attributable to COVID towards the end of the year. As I mentioned, the Australian experience, we've been blessed with being an island so far away, and we could lock down and keep COVID out of our country for quite a long time. That out of the 27,000 odd end-stage kidney disease patients that is equally split between transplant and dialysis, we had only about 215 cases about 132 patients with dialysis, of which 15% was the mortality, and in transplant there were only 83 cases all over Australia as of last week. And of course, this is an evolving situation because the pandemic is still upon us, and there's quite a high number of cases that are at the moment in Australia. What about COVID in home therapy? So early on in end-stage renal disease patients' history, it was found that those who are in-center hemodialysis had a much higher risk of COVID, acquiring COVID compared to those on home therapies. The very low incidence of COVID reported in PD patients, and very small number of reports. So this one is from China, which had less than 1% of their PD patients in a hospital come back with COVID. And mortality is similar to that of hemodialysis. Interestingly, the effluent that comes out of the PD patient, there's been multiple studies which have shown that the virus is not found in the effluent, and therefore it's quite safe for you to dispose the effluent as usual. What about home hemodialysis? Again, the acquisition risk is lower in home hemodialysis. Prevalence is much lower in home hemodialysis, almost half of that of in-center hemodialysis patients. But this mortality is very similar because of similar comorbidities that they've had. A systematic review of several studies, about 300 odd studies looking at 300,000 patients with chronic kidney disease, have shown that the incidence of COVID is much higher in those who are on dialysis compared to CKD, not on dialysis and transplant. And the mortality, whether it is CKD or transplant, was much higher compared to those who had CKD but no COVID. So about 3 times higher than with COVID than no COVID. Unfortunately, most of the therapeutic trials did not include end-stage renal disease patients, so it's very difficult to know if any of those drugs may specifically work in the end-stage population, although end-stage kidney disease patients are higher risk of mortality. So treatment options are often extrapolated from non-ESKD population. And then we know that because of the thromboembolic phenomenon and the fact that high erythropoietin use can result in thromboembolic situation, we try and reduce the target hemoglobin concentration in these patients. This is not uniformly performed, and there's no data to support that, but some centers do this. We don't necessarily routinely do this because of lower incidence of COVID in the community so far, but in those with high incidence of community, it will be really important. There's a good question on, would vaccination reduce the impact of COVID on AKI or GN? Is there any data? Krishna, I really don't know. Vaccination would definitely reduce the incidence of serious COVID and therefore consequently systemic inflammation related acute kidney injury. But interestingly, vaccination itself has thrown a lot of GN, de novo, and relapse of GN because of the immune response. Not a lot. I think there are case reports of that. So that question on whether COVID-associated GN would come down, but would that mean the total GN numbers would go down is not unclear. Now, if you look at COVID therapeutics for CDC says that those who do not require hospitalization can be managed if they have been found positive and have symptoms with monoclonal antibodies. Now, this is something that's come up in the last few months in the US, and it's now being used in Australia as well. So Trovimab is available, and I'm sure monoclonal antibodies are being made available in some countries and not so commonly available in others. If they have been discharged from hospital, their outpatient management involves simpler medications. The hospitalized patients, the treatment protocol is very similar. You've got dexamethasone, either alone or in combination with remdesivir, especially in immunosuppressed population. And addition of interleukin and Janus kinase inhibitors such as baricitinib and tocilizumab in those who are requiring oxygen to high flow device or non-invasive ventilation. And those who are quite sick and requiring intermittent ventilation and ECMO end up requiring dexamethasone and tocilizumab together. So in the different phases of COVID, there are different therapeutic agents that are being used. So these are all the monoclonal antibodies, and so Trovimab. Remdesivir is being used in the hospitalized patients. Convalescent plasma is used sparingly in the US, especially for the immunosuppressed, especially those such as transplant patients and hem-onc patients. And of course, dexamethasone, remdesivir, and baricitinib in the hospitalized, but those who needing oxygen. We know that there are newer drugs that are coming up. Merck had released some information on molnupiravir, which is a new drug that is again useful in the early symptomatic phase. And Pfizer has now come up with a new drug called Paxlovid. These are both antiviral drugs that that work on the viral replication mechanism and might be helpful in managing COVID early on, especially in the symptomatic phase within the first, if administered within first 5 to 7 days. The important thing is we don't know if these have any interaction with kidney disease or kidney function. We know for sure that Paxlovid or the Pfizer drug has got a protease inhibitor, which is ritonavir boosted, and therefore ritonavir related drug interactions, which are clearly well known in the transplant and immunosuppression group, would still be a problem here. But interestingly, Pfizer is also doing a pharmacokinetic study in chronic kidney disease patients so that we can identify how to dose these based on renal function, and that'll be something worth looking at. End-stage patients continue to shed virus for a longer duration. They seem to have a prolonged duration of PCR positivity. But as you can see here, the red dots are the ones where not only PCR was positive, but also culture positive. So in about 45 patients tested here, most of them were PCR positive, but culture negative. Only about a couple of patients were PCR and culture positive, and up to about a month after their initial test being positive, and not more than a couple of weeks after their symptoms. And this is another study which looks at the CT values of the PCR cycle to see how much virus load is there, and that kind of corroborates with the transmission risk from that particular person. As you can see, by about 14, 15 days, most of the patients on dialysis would have CT values that are quite high, indicating that their viral load is smaller and therefore transmission risk is low. This very interesting study done in UK looking at CKD patients and non-CKD patients and how long do they take to actually get a negative SARS-CoV PCR after COVID infection showed that those who had lower GFR had an increased number of days of positivity with PCR, And in fact, it formed a kind of a trend here where you can see as the GFR goes down, the number of days of PCR positivity goes up. And older age, male gender, and severe disease, along with lower EGFR, where and immunosuppression, where risk factors for prolonged virus shedding. So if someone's transplant or GN who's on significant immunosuppression, as in this patient who was anti-GBM and was on cyclophosphamide, continued to have viral shedding, which was active viral shedding, live virus shedding for about 128 days after the initial test positivity. So in immunosuppressed patients, it's important to kind of look at not only the PCR, CT values and neutralizing antibody titers before they can be released into released from isolation to ensure that they're not at a risk of transmitting the virus to others around them. Immune responses to COVID virus in the dialysis patients is quite good. Actually, immune responses are durable for about 6 months. So if there's a dialysis patient who develops COVID and they have immune response against COVID and protective immune response for a duration of about 6 months. And this immune response actually is significant. Those who have the immune response do not develop reinfection for about a period of 6 months. But their antibody levels do decrease with time. And even though they decrease with time, they seem to have robust T-cell immune response. And the rate of decay correlates with the severity of infection. So the more severe the infection was, the more robust, persistent the immune response was. And also, those who are very elderly and diabetic and those who had hypoalbuminemia had increased rate of waning. And this similar study done in US also shows that the post-viral infection immune response is quite sturdy and remains for about a period of 6 months. I wouldn't go too much into vaccine efficacy in end-stage renal disease. It's a major talk in itself, but suffice to know that end-stage kidney disease patients have good vaccine immunogenicity rates of 86%. Diabetics have a lower immunogenicity rate compared to non-diabetics. And first dose rates are lower than general population. Second dose rates are also lower, but not too far away from the general population immunogenicity risk. These 2 doses impact only lasts for about 6 months. And we now know that dialysis patients along with transplant patients need the 3rd primary dose to keep them safe from another wave of COVID. I'll quickly go through, in the next 2 minutes, go through transplant, because I think someone asked a few pointers on transplant. Transplant numbers worldwide had come down because of COVID pandemic, especially living donor kidney transplants. You can see a lot of black dots there, did not happen in many centers and for various reasons. Earliest data from transplantation and COVID showed that lung transplant patients were a higher risk of mortality. I did show that 78% of patients had hospitalization requirement and a higher risk of death. But the overall mortality was around 20%, very similar to the general population. Most of them had similar symptoms compared to general population, except for one change where there were a lot of GI symptoms in transplant transplant recipients. And even if they had very minimal symptoms, there was significant radiological changes in the X-ray that was seen. Uniformly, all case reports and case series of all organ transplant, not just kidney transplant, show that there's significantly higher risk of acute kidney injury than non-solid organ transplants. And that is possibly explained by not just the severity of the COVID, but also the fact that they're all on calcineurin inhibitors, and the toxicity levels of calcineurin inhibitors and their impact on the kidney is well described in all solid organ transplants as well. They also have a higher risk of concurrent infections, including fungal infections. Interestingly, there's not much data of rejection. In fact, there's very few reports of rejection happening because of immunosuppression reduction during COVID, despite the hyperinflammatory response that you do see it is non-specific and it doesn't seem to trigger a rejection phenomenon. Although there are a couple of reports of increased donor-specific antibody titers after a COVID infection. COVID-related mortality rates were quite variable in various initial studies. And there was always the question, was the increased mortality related to the transplant status, or was it because of their underlying comorbidity? So many studies have looked at this, and the overarching finding is that in most small studies, COVID-related mortality is similar to general population if you control for all the comorbidities such as CKD, COPD, hypertension, diabetes, and cardiovascular disease, indicating that the immunosuppression is not necessarily, as long as you're handling it carefully, it's not necessarily quite have a negative effect. However, there is an increased risk of acute kidney injury and renal replacement therapy, possibly attributable to calcineurin inhibitors and their drug interactions and the toxicity. The smaller studies have looked at mortality risk amongst solid organ transplants and non-solid organ transplants who are hospitalized, and found that the mortality is possibly similar. The slightly larger studies looking at 100 or more transplant patients have shown that there's an increased mortality in kidney transplant or solid organ transplant population compared to the general population. And therefore, it's possible that there is a slightly increased death rate in transplant population once controlled for all the other comorbidities because of the immunosuppression, but it's not phenomenally big enough to make a big difference in how we manage them. And it's likely that with vaccination and other therapies, this difference is going to come more clearer. There are several studies looking at systematic reviews, looking at large number of patients, which again conclude the same, that there's a similar mortality to general population, but there's a much higher risk of acute kidney injury. What about those who are on wait list versus transplant? This is a question, especially during the raging pandemic, whether we keep patients in the wait list or do we give them a transplant? What makes it better? And clearly, those who are on wait list have a higher risk of acquiring COVID because of the fact that they need hospitalization, they need medical care, or they need to come into the centers for dialysis, and they are moving about and they're at a higher risk of acquiring COVID. But COVID-related mortality was lower in those who are on the wait list compared to the dialysis population, compared to the transplant population. And most of this transplant-related mortality was driven by the higher age group, about 80 to 90-year age group who have had transplants previously. And therefore, on balance, it appeared that the risks are not very different. And in fact, because it's not very different, you should continue to transplant these patients during the pandemic. So while the first wave happened, living donor transplants stopped, but deceased donor transplants were reduced considerably. During the subsequent waves, transplant activity had continued because at a high viral risk area, there's not significant difference between the mortality risk of candidates and recipients. Whereas at the low viral risk area, recipients had a lower mortality compared to candidates who are waitlisted. And therefore, candidates need to move from this group to actually receive the organs they have and be protected. Mortality rates have also come down with time in the transplant population. As you can see, from April to December, there's a reduction from 20-25% to about 15 to 20%, which is good. And this is likely to improve better with newer therapies that we've got. A few pointers. Immunosuppression reduction, antimetabolite withdrawal is the most important and most standard thing that is being done, especially mycophenolate and azathioprine, because lymphopenia is a poor prognostic marker in transplant. CNI reduction happens, but it's often not completely withdrawn, and the reduction happens to reduce the targets from the usual levels to almost half of them during the infection. and watching out for interactions with the other drugs that are being used for treatment. And if you're using IL-6 inhibitors, a temporary CNI holiday is not unreasonable in those patients. mTOR inhibitors are never good for lung infections, and even so for COVID, and therefore those who are on mTOR inhibitors, we usually change them to CNI if they are there, or stop the mTOR inhibitor completely. Now, several monoclonal antibody treatments are available now for kidney transplant population, including drugs such as molnupiravir and Paxlovid are coming. All of these are likely to improve the transplant outcome in general. Post-COVID immune responses are poor in kidney transplant. They also have prolonged viral shedding, much more than the dialysis population. And as I mentioned, poor immune response to vaccine, therefore needing a third primary dose. And interestingly, there's a small study on long COVID and kidney transplant patients, which showed about 1/3 of them continue to suffer significant graft dysfunction after COVID, apart from other similar long COVID symptoms. So I'll come to a stop here. COVID and kidney disease interface has several implications. Very high risk of acute kidney injury early on in COVID patients because of various mechanisms, including systemic inflammation, tubular injury, and glomerular diseases. There's a lot of interaction of immunosuppression with COVID in glomerular diseases. Patients have a higher risk of acute kidney injury as well as mortality. Chronic kidney disease and end-stage renal disease patients have a higher risk of AK progressing to needing dialysis as well as mortality after COVID, and higher incidence of AKI patients turning to develop ESKD in the long run. Transplant mortality is very similar to dialysis non-transplant population, as long as they are effectively managed with their immunosuppression and necessary treatment. With the long COVID, there's going to be significant implications. The number of CKD patients and end-stage renal disease patients we might see in future. And hopefully with vaccines, the pandemic would abate and newer monoclonal therapies would help take care of our most vulnerable population of transplant GN patients and dialysis population with COVID. There's one question about any point in measuring antibody levels. Unfortunately, there's no cutoff antibody levels that seems to be useful unless we have a trend. And so this is not widely used, but in some centers, there's studies based on immune responses to vaccines. And so in a research setup, it's being used, but not necessarily in the clinical setup.
Great. Thank you very much, Basu, for a very comprehensive overview of the impact of COVID on kidney disease and management of kidney disease in the context of the pandemic. I'd really like to thank our audience for their engagement and for the wide range of questions that were asked. I think they too were very helpful in helping us understand kidney disease in this context. We're going to launch a poll, and I request our attendees to please respond to that. It really helps us manage the webinar series. We do value your feedback immensely. If you can stop sharing your screen, Basu, we'll just talk about our webinar for next week. So Xavier will just launch that. Next week, we have a rather unusual but very important topic. We're going to talk about the impact of COVID-19 on climate change. And we have an ANU team next week on the 24th of November, same time, 7:30 p.m. Professor Mark Howden, Anna Greta Hunter, and Will Grant, who will talk on this important topic. Before we end, if we can go to the next slide, please, Xavier. I'll just tell you a little bit about the ANU COVID-19 peer support program. We've got the website link there. Please do go on the website and have a look. If you are a medical or healthcare professional, you can register as a volunteer for the program or seek support using this link. And if you have any feedback, you can contact us via email or follow us on social media. With that, I would like to thank everyone and end the session here.
Thank you everyone for your time, and hope to meet you soon.
Thank you very much, Basu.
Bye.
Bye.